All right, so thank you everybody for joining us. My name is Peter Bayich. I'm the director of the Center for Men's Health at Cleveland Clinic, and I'm just going to share my slides here. We're going to do a brief presentation, and then we will be opening up the floor for any questions that you guys have at the end. Feel free throughout to send your questions in the chat, and we'll make sure to address them at the end. So let me just figure out how to share my screen here. And it's not right. Let's see. If my slides are not showing, somebody please let me know. All right, so today we're going to be talking about updates in testosterone replacement therapy, modern solutions for a common problem. And we have a esteemed panel here. Dr. Neil Park is a urologist based out of Akron at our Cleveland Clinic location there. He also has clinics at Fairlawn and Medina. We have Dr. Scott Lundy, who is based out of the main campus and also sees patients at Independence and Beechwood, and Dr. Ray Pibole, who is also based out of the main campus and sees patients at Independence and Middleburg. I myself also see patients at Cleveland Clinic main campus, Independence, and Beechwood. So I want to start with just a few slides to discuss what testosterone deficiency is. Now, you may have heard several different words or phrases all kind of talking about the same thing, everything from low T to male menopause to low testosterone. And probably the preferred term nowadays that we like to use is testosterone deficiency, because really what we're referring to is deficiency of a hormone and not just something that we're trying to improve for no other reason. We're talking about improving testosterone in men who don't have enough of it in their body. So if you look at what happens with average testosterone levels with age, as a man gets older, as we go left to right on the screen here, his testosterone level declines. These are average numbers. And as you can see here, if we look at the average numbers, no matter the age, they're still in a range that would be considered normal, quote unquote. So you see a line there on the bottom that's kind of the level under which we would typically recommend treatment. So the average guy in his 70s or 80s does not necessarily need testosterone replacement therapy for testosterone deficiency, but some men do experience it, and we'll talk about a little bit more detail about how we determine who needs to have treatment and who does not. Figure out how to advance. Okay, so how common is testosterone deficiency? Well, depending on the study that we look at, rates have been reported ranging from 2 to 39%. And when we talk about testosterone deficiency, these are guys who not only have an abnormal lab value, but they also have symptoms associated with it. So there are a number of different types of symptoms that can be attributed to testosterone deficiency. And we kind of lump them into a couple different categories. So some of the sexual symptoms are decreased libido, another word for low sex drive, or weaker erections. Although importantly, testosterone deficiency is definitely not the most common cause of erectile dysfunction. In some men, it can contribute. There are mental symptoms like fatigue, depression, irritability, and poor memory and cognition. And then physical symptoms like weak bones, decreased muscle mass, breast enlargement, increased body fat, anemia, and diabetes. Just because you have some of these symptoms does not necessarily mean it's due to testosterone deficiency, but these are some symptoms that we see in some men with testosterone deficiency that we would expect might improve with correction of that hormonal problem. Some other conditions that can be associated with testosterone deficiency include diabetes, sleep apnea, metabolic syndrome, COPD, kidney failure or dialysis, osteoporosis, having had a history of an organ transplant, being on treatment with steroids or opioids, or HIV. And there are a number of other ones not shown on the screen. So how do we diagnose testosterone deficiency? Well, we have to check a blood test. And in fact, we have to check a blood test twice. So we need to check a testosterone level. It has to be drawn in the morning before 11 o'clock, ideally even before 10 o'clock or earlier, because that's the point in the day for most people when the testosterone levels are at their highest. So when we look at what's considered a normal lab value, that refers to a morning blood test. So we need to have basically 2 blood tests to confirm that the level is low, and very importantly, there needs to be symptoms present. So those symptoms that we just talked about, there has to be both symptoms and a low testosterone level. So what might an individual experience if they have treatment or correction of their testosterone deficiency? Increased energy level, increased muscle, decreased body fat, improved control of their diabetes, increased bone strength, improved depression or mood, improved motivation, increased libido or sex drive, and improved erections in some men. All right. So when we're thinking about treatment, it's important to take into consideration what the risks of treatment might be. So testosterone replacement therapy might make the blood more thick, particularly with certain types of treatments that we'll talk about. Another name for that is erythrocytosis. In men who have sleep apnea, it can actually make sleep apnea worse. So it's important for those who have been prescribed a CPAP that they make sure they're using it while they're on treatment. It can worsen acne. It can cause infertility. In some men, it might lead to aggression. And importantly, testosterone gels, as we'll discuss a little bit more in a few moments, do have the potential of transferring to other people who come in contact with the area where those gels have been applied. There's been a lot of concerns over the years about testosterone and its effects on the heart. But importantly, um, recent studies confirm that testosterone replacement therapy for men who have low levels, when they're treated and put into the normal range, is actually safe for the heart. And some other studies have shown that it might actually be protective. For men who have a history of prostate cancer, some of them can be prescribed testosterone in certain situations, but this should really be managed by a urologist with experience in both testosterone replacement therapy and prostate cancer. So there are a number of different types of testosterone replacement therapy, and we're going to go into some of what's kind of new out there during the session today. Injection therapy has been around for a long time. There are a couple new options that we'll discuss. Topical treatments like gels and creams are something that we commonly use that has also been around for a long time. Testosterone pellets are actually implanted pellets that are put underneath the skin that are a slow release form of testosterone. Oral testosterone is something that's really been gaining a lot of attention recently, we're going to talk about. And there's also an intranasal spray type of testosterone. We'll also get into a couple other options that aren't necessarily testosterone, but that do have the ability to improve your testosterone by other means. I'm just going to spend a few moments talking about some topical testosterone, or things like gels and creams. I don't want to get too into detail on this, but just to show you that there are a number of different topical testosterones available. Gels, creams, even patches. In general, gels and creams, as I mentioned, have a risk of transferring to other people. So it's really important to be careful after applying it in the morning. Be careful who comes in contact with that area. In general, as I'll mention in a moment, insurance coverage for these is quite good, although there is a column there on the right that shows approximate costs for folks that are paying out of pocket. So there's good insurance coverage for these. They're carried at most pharmacies. There's no pain associated with administering them. And it's pretty easy to adjust the dose as needed based on blood work that we would check once you're on this treatment. Basically just increase or decrease the amount of gel that's being applied, or cream. However, disadvantages is that risk of transference, so people that you don't want exposed to testosterone. If you take a shower after putting on a gel or a cream, you'll have to reapply it afterwards. It only lasts for about 24 hours. So if you miss a day, for that day, your testosterone level is going to be low again. Also, at least in my experience, it seems that the levels that guys get as far as their blood tests while on treatment aren't quite as high as they might be with other treatments. All right. Now, Dr. Bole, I'm going to turn the floor to you to talk about injectable testosterone.
Thanks, Dr. Byach. All right, so let's talk a little bit now about this other formulation of testosterone, just another way to get it, as Dr. Byach had mentioned. There are four main types of injectable testosterone that we'll cover. One kind is called testosterone enanthate, or you'll also hear that referred to as something called Xiastad. We'll talk a little bit more about that in later slides, but that essentially is testosterone that can come in an auto-injector formulation. There's another kind that's called testosterone cypionate, also called depot testosterone. That one has very good insurance coverage. It's a little bit more of the traditional type where you will draw it up yourself with a needle and inject it at home yourself. And we'll go into that a little bit more in detail in further slides as well. There is the third formulation on this slide, testosterone undecanoate, also called Aved, if you've read that anywhere. That is a slightly longer acting formulation that's injected with a little more time in between, and that's done in the office. And then finally, I also wanted to mention testosterone pellets. These aren't strictly injections, of course, they are pellets, but they are inserted under the skin. And so I just wanted to mention that these are done in the office as well, just like the Aved. So you may be curious to know, what is injectable testosterone? What's it made of? So this is a little technical here, but for those who are interested, essentially if you were to just inject yourself with straight testosterone, it would get out of your body very quickly and it wouldn't help you and you'd have to inject it very often. So in order to make it last longer, it is attached to another compound called an ester, and that helps it dissolve in an oil formulation and it helps it to last in your body for longer. That testosterone ester is then dissolved in a certain type of oil, and the oil depends on which formulation we're talking about, one of those three different injectable kinds. And then once you inject it into your body, it gets slowly released and gives you a nice sustained level while you're in between your injections. Next slide. So what are some of the benefits of injecting testosterone? And Dr. Byach went over some of this already, but transference is one of them. So unlike the topical version, this won't transfer to anyone else. So for example, a young child or women in your household. Injections also have quite a predictable effect on your testosterone levels. So sometimes you can have issues with absorption of gel through your skin, but when you are injecting it, we have a much more reliable way to predict what that's going to do to your testosterone level. The third benefit is that it's typically quite cost effective. Now, I mentioned that one of the formulations, depot testosterone or testosterone cypionate, typically enjoys very good coverage with insurance. But even for some of the more new formulations like Xiastad, which is the one that comes with the auto-injector, with the appropriate requirement for the medication and documentation from your physician, you can have a copay that's quite low, often even $15 a month for many commercial insurance plans. And there are a lot of patient assistance programs as well if you don't qualify for one of those that we can help you apply for if this is something that's indicated for your health condition. And then one of the other benefits of injections is that you don't need to inject every single day. And so that means that you don't need to necessarily remember a daily medication, which can also be nice. So what are some drawbacks of doing a testosterone injection? Well, for one, if the injection is the type that goes into the muscle, that can sometimes be painful or uncomfortable. A second potential drawback is that the injection can sometimes be difficult to do for yourself. This specifically refers to the testosterone that doesn't come in the auto injector. If you have the auto injector, that does make it a lot easier for you to inject. But we do help patients learn how to inject with a urology teaching visit for those who do find that the testosterone depot injection is their best option. So even though it's difficult, we do help you to learn how to do it and make it easier. Another potential drawback to be aware of is that if you have testosterone injections and you're learning how to do it without the auto-injector, that does involve a potential other prescription for needles and syringes that you need to make sure that you get at the pharmacy. And we've all been there with prescriptions that could potentially be subject to back orders or delays. So another reason that some men do find that the auto-injector is more convenient for them. And then finally, the last potential drawback that I want to mention with the injections is that since we're injecting less often, maybe every few weeks or so or every week, the testosterone level will fluctuate. So you'll see a high peak of your testosterone level within 1 to 2 days of the injection. And then because of the way it's formulated, you'll see the testosterone level decline somewhat until it's time for your next injection. Now, for most people who are doing well on injections, that doesn't necessarily mean that they're going to have bad symptoms in between. But for some men, the fluctuation in the testosterone level can affect them. And towards the end of their cycle, just before they're due for their next injection, they may have some effects where they're really feeling low energy, low mood, or effects on their sex drive. So how often do you need an injection? And this is going to vary depending on which of those formulations you're being prescribed. So there's a long-acting formulation, which we would consider every 1 to 2 weeks. That's going to be the testosterone enanthate, which is the auto-injector, Xiasted, or the testosterone cypionate, or depot-testosterone. Both of those can be done every 1 to 2 weeks. Then there are extra long-acting versions. So the one called testosterone undecanoate, that is typically injected at baseline, then at 4 weeks, and then every 10 weeks thereafter. So the benefit of that one, which is done in the office, is that you eventually can get out to doing it less frequently. And then finally, for the pellets, which are also done in office, they're also extra long-acting. Those are about every 3 to 4 months. Now, you may also be curious to know, well, what part of the body is getting injected? So first off, like we were mentioning before, if it is possible for you to do this injection at home, we always have a trained urology nurse visit to teach you or potentially your family member how to inject testosterone medication. So for the types of testosterone that are subcutaneous or injected just under the skin, they can be injected into the thigh or the belly. Alternatively, for the pellets that we place, that your physician will place in office, those are typically placed in the glute area. It's also possible to inject testosterone cypionate. That's one of the formulations that's typically done intramuscular, but recent data has also shown that it's likely safe to inject it subcutaneously, and it probably has similar effect and similar effect on your levels of testosterone in your blood as if you did it intramuscular. So that's a potential option as well. And it may also be less uncomfortable than injecting that medication right into the muscle. The other way to inject testosterone is intramuscular, like we just talked about. If you are doing it that way, typically the locations are going to be in the glute area or in the hip. As well as for the long-acting testosterone version that we do in office, the one that goes every 10 weeks, that's typically in the glute area. So this slide is just showing the Xiasted auto-injector that I was referring to. This is the one that's typically done every week. It's quite easy to use for those who don't want the hassle of syringes and needles and things like that. So this slide just shows how the auto-injector works. You remove the cap, you squeeze the area that you want to inject and you hold it steady, and then you simply push in the auto-injector and you hold for 10 seconds. The nice thing about it is that the way that the auto-injector works, you don't actually see the needle. So this can also help if you have needle phobia or feel sick at the sight or the thought of a needle. So what are some of the side effects that are known to people who are doing testosterone injections? So one is relatively minor, but worth mentioning. You may get some redness at the site where you're doing the injection. Sometimes guys will notice a little bit of lumpiness or nodules right under the skin, and sometimes some mild bruising. Then, as Dr. Byach had mentioned earlier, there's an increased risk of getting thicker blood with testosterone injections, and this can often be driven by the fact that the testosterone levels are fluctuating quite a bit. That can sometimes be one of the reasons that you're getting thicker blood. And that's the point I mentioned here in that third slide. That's a little bit more of an issue with the intramuscular formulation. The next risk I want to mention is specific to the testosterone and undecanoate, the AVID. And again, that's that one that you do every 10 weeks or so. That one is required to be done in the office with a 30-minute monitoring period after, specifically for the risk of something called pulmonary oil microembolism. Typically, you'll notice coughing, but a serious complication potentially would be trouble breathing or something like that. That's very rare, less than 2% of the time, but that is the reason, in addition to if you were to have an allergic reaction, that we would want to do that one in office and watch you to make sure that that doesn't happen. And then the last potential side effects I want to mention are specific to Testipel. Those are the testosterone pellets. Those require a minor procedure in the office. So there's a potential for developing a little bit of scar tissue at the site where you're having the pellets placed. There's a potential risk that some of those pellets might extrude out. You might see a pellet migrate or work its way out potentially. It's not common, but it can happen. Or the potential for a small infection or a little bit of drainage from the site where the pellets were placed. Again, most people who are getting these done have very good results, but these are all potential side effects that can happen.
All right, thank you, Dr. Bole, for that great overview. Now I'm going to give the floor to Dr. Neil Parekh, who's going to be talking about oral testosterone.
Thanks, Dr. Byach, and thanks for all of you in the audience joining us today. I look forward to sharing a little bit of information about some of our newer therapy around testosterone deficiency, which is the oral option. This is a nice table here that shows that there have been a number of options, and we've reviewed a number of these options during today's discussion. But the newer options we see here on the right, circled in red, are our oral options or pills that we have now available that are FDA approved to treat testosterone deficiency. And these have been started as recently as 2019 and 2021, which include Jatenzo, Tilando, and Kysotrex. Here you can see the options. As I mentioned, these are oral options in a pill form. So for many patients, it's surprising to them to hear that there has not been a pill option available to treat this issue. But given the fact that it is now a pill that gives patients a different route of treating their deficiency, which may be convenient for them. Historically, oral testosterone was considered to be toxic to the liver, and that's what many patients may see online, or what many even physicians were taught in the past. However, these newer options that were developed in the last few years avoid the liver toxicity because they can bypass the liver and be metabolized through the lymphatic system. Here's a nice schematic reviewing that. Once these pills, which is essentially testosterone undecanoate, which is a lipophilic molecule, is absorbed into the lymph system, you're able to bypass the liver through the thoracic duct and avoid absorption into the portal veins. So you avoid metabolism by the liver and avoid the liver toxicity, liver cancers that we're seeing with older forms of oral testosterone that are no longer available. So as far as oral testosterone goes, there are some reasons why we may want to use oral testosterone for particular patients. As we've learned, intramuscular injections can sometimes be painful or even difficult to administer for some patients. We also learned that topical therapy can potentially rub off on family members or loved ones, so that is a potential risk. And also, testosterone pellet implantation can be inconvenient. It can cause pain, and frequent visits to the office can also be an issue with convenience. So one of the things I like to explain to patients in the office is something called the 4 C's. And this is what I share with them when trying to decide which form of testosterone may work best for them. Now, unfortunately, cost does come into play when deciding what therapy may work best for patients. So it's important to find an option that's affordable. We also want to take into consideration compliance. If patients are not going to remember to apply a gel every day, that can affect the compliance with the medication and eventually, or essentially affect the ability for it to work well. So we want something that's going to be easy for the patient and easy for them to remember to take. So if patients are already taking pills twice a day, an oral option may be an option, which we'll discuss. Concentration. Many patients may come see us and have tried other testosterone therapies in the past, and for whatever reason, they may not have felt great on it, and their blood work may not demonstrate a normal testosterone level while on therapy. So if they're not getting a good testosterone concentration on their blood levels and they don't notice an improvement in their symptoms, it's reasonable to try a different form of testosterone therapy, and sometimes an oral pill can help. And lastly, convenience. So some patients do not want to come to the office every 3 or 4 months for pellet insertion, or have to inject themselves in the butt or the thigh, and that can affect the convenience. So an oral pill, which is easy to travel with, can sometimes help with the convenience factor. So some of the benefits of oral testosterone, as we discussed, is the lack of transference because it's a pill. If you're afraid of needles or have concerns with needles, you don't require it. If you're already taking pills, it's a great option. It's something that many patients will just add to their pill box, so it's easy for them to remember. And one of the things we're also finding is there may be a lower risk of erythrocytosis, which means thickening of the blood, which is one of the complications of testosterone therapy. And so for patients that may have that issue while on other therapy, sometimes switching to an oral testosterone can help reduce that risk. So what are the different options? There's 3 FDA-approved options that I mentioned. So the first one we'll talk about is Kysotrex. Kysotrex is not available using your insurance. It's only available via cash pay. It's about $150 a month. So it comes in 3 capsule strengths, 100, 150 milligrams, and 200 milligrams. And it's having those options allows us to titrate the dose. You're not required to take it with food, which is something you'll learn is required with some of the other oral options. So it does not need to be taken with a fatty meal or with food, which is sometimes beneficial for some patients. And having these 3 strengths allows us to titrate the dose for patients for the maximum benefit. Another option is called Tlando. So the Tlando, the benefit is it only comes with 1 pill. So the benefit of that is patients don't need to worry about titrating the dose. It's only 1 standard pill. But the downside is it has to be taken with food. So if you're not taking it with food, you're not going to get potentially enough absorption to get your testosterone level in a normal range. So while it may be easier to only have 1 option, you have to take that into consideration. So I tell patients, if you're a person that doesn't like to eat breakfast, or maybe they only eat a banana or a granola bar in the morning on their way out the door, an oral option like Tlando may not work for you. And the oldest oral option, the one that's been out the longest, is Jatenzo. This also comes in different doses. That's the benefit of that, again, is to be able to titrate the dose for patients. So less of an emphasis or requirement of having to take it with a meal, because if you're someone that does not eat a large meal or fatty meal with breakfast, for example, we can titrate to a higher dose if needed, if more absorption is required. The starting dose is 237 milligrams twice a day. So you'll see the trend with most of these oral options is that the pill needs to be taken twice a day. The label recommends taking it morning and evening, but can sometimes also be taken morning and afternoon, depending on your schedule. And so there's allows us to kind of work with each patient individually to find the type and dose that works best for them. So what are some of the side effects of oral testosterone? Now, we know that high blood pressure is a class effect of testosterone therapy, but there is a black box warning for oral testosterone pills in regards to blood pressure. So it's something I recommend all patients monitor while on testosterone therapy, whether at home, at the pharmacy, with their primary doctor, is to keep an eye on their blood pressure. It can also cause headache. As we discussed, thickening of the blood, nausea, and weight gain are just a few of the more common side effects. So really just to summarize, there are several commercially available FDA-approved options that are oral to treat low testosterone or testosterone deficiency. These oral formulations have favorable safety profiles without the concern for liver toxicity that was seen in some of the older formulations. And lastly, due to the black box warning, blood pressure should be monitored in patients while taking oral testosterone. Thank you.
Thank you so much, Dr. Park. For the last section of our presentation, before we open it up to questions, I want to invite Dr. Scott Lundy to talk a little bit about treating testosterone while maintaining fertility. Scott?
Good evening, everyone, and thanks for that introduction, Dr. Bayach, and thanks to the other panelists for making my discussion streamlined with all the great information you've already shared. I'm going to focus mainly on men who would like to preserve or restore their fertility during testosterone treatment. Next slide. So as many people know, testosterone therapy does cause problems with fertility. Sometimes this isn't relayed to patients as they're placed on testosterone treatment, but it really is a common phenomena that you need to be aware of. This is a recent research study that showed that men being put on testosterone have normal or detectable signals of hormones that tell the testicle to make testosterone, but during the treatment with testosterone treatment at the end of cycle bars, you see that that goes away. It does, however, come back at 3 months, and then 1 year later, it remains stable. This suggests that when a patient is on testosterone, the intrinsic signals to make the body's own testosterone tend to go away, and we'll come back to that. Next slide. This is related to sperm count, and we'll talk about why in just a moment. But essentially, during testosterone treatment, sperm production drops dramatically, or in most cases, stops entirely. And then after 3 months of stopping the treatment, sperm production does come back, and that level is maintained at 1 year. What we think happens is that hormone production tends to come back to some degree, but that sperm production may not fully recover back to where the levels were before testosterone treatment in all cases. Next slide. So the reason this happens is that the testicle is normally very high in testosterone, and that's what allows spermatogenesis to occur. Without this high level of testicular testosterone, the process doesn't work. What happens when a man is on testosterone is that because this internal production stops, the circulating testosterone around the entire body may go up, but the levels inside the testicle do not. And this essentially shuts down sperm production until we can restore that intrinsic testosterone production. Next slide. Now, not all testosterone therapies cause infertility. There is a treatment called Natesto, which is a nasal spray of testosterone that's designed to be rapid onset and only last a short period of time. You can see in this graph here that over the course of 1 to 2 hours after treatment with this product, the levels do indeed rise. But after 2 to 4 hours, those levels fall right back down to where they were before. And this product is designed to be used 3 times a day as a result of that short half-life. Next slide. We think that this allows the body to recover in between those treatments and allow for some sperm to continue to be produced despite being treated with testosterone. This may not be full sperm production, but it's in most cases enough to allow for a pregnancy to occur either naturally or with assistance, like intrauterine insemination or IVF. Next slide. It's important to know that this medication is short-acting and that it may not suppress normal testosterone production, but as a result, some men think that the symptom benefit from this medication is not as strong. It also requires frequent dosing, and importantly, this can cause side effects like nasal irritation or bloody noses in some cases. This is also not frequently covered by insurance and can be relatively expensive, on the order of $100 to $200 per month. But for some men who desire to have fertility and have some treatment for their low testosterone, this is an option. Next slide. There are other medications that we can also use for this purpose, and there are two main categories we'll talk about today. The first is called SERMs, or selective estrogen receptor modulators, and a common example is a medication called clomiphene, or Clomid, which you may be familiar with because partners or female partners are often placed on this medication for fertility as well. This medication is only FDA approved for females, but we've been using it for men with infertility or low testosterone for many decades. And it works by essentially binding the estrogen receptor in a different way, and it allows the signal to the testicle to become stronger to make sperm and testosterone. This is an oral pill that's given 3 times a week, and it does not require injections or gels, but is in fact oral, which is convenient for some men. Next slide. It does, however, in some cases cause headache and breast pain or breast fullness. And it's important to note that not all men on this treatment will have an improvement in their sperm counts, but many will have improvements in their symptoms related to their low testosterone. So if we look at this simply from sperm production, 3 in 10 men will improve, but 1 in 10 will paradoxically worsen for reasons that we don't quite understand. We think this medication is best for men with low FSH and or low normal testosterone. In other words, men who are just on the cusp of being low, but still want to have fertility as an option. Next slide. The second category is called aromatase inhibitors. This includes medications like anastrozole, and this medication blocks the body's normal conversion of testosterone to estrogen. Now, estrogen is present in all of us to varying degrees, and this medication lowers the estrogen levels, thereby increasing the testosterone and also removing that negative inhibition that men have from the estrogen on their intrinsic testosterone production. So it works in 2 ways. The medication is also an oral pill that we often start 3 times a week. And similarly, there are side effects to this medication, although they're typically well tolerated. Next slide. Side effects include hot flashes and joint pain. And then this is a medication that we want to be careful with in using long term, particularly more than 2 years, because it can cause weakness of the bones in some cases that we would need to either treat or at least be aware of. Similarly, not all men will improve on this medication in the short term, and those who do improve may have a requirement to stop the medication after 2 years because of those bone health issues we concern ourselves with. Also, 1 in 10 men placed on this medication will have worsened sperm parameters for reasons that we don't fully understand. We think this is best for men with high body mass index or high estrogen levels who need a temporary boost in their levels prior to completing their fertility journey and then going on to definitive testosterone therapy in the future. Next slide. Finally, the medication called human chorionic gonadotropin, or HCG, is another option. This medication mimics the normal signal to the testicle and tells it to make testosterone and sperm. The benefit of this is that even when men are on injection or gel formulations of testosterone therapy, this medication can provide enough of a signal to the testicle to continue to make both testosterone and sperm. In other words, we use this in conjunction with those other formulations of testosterone in many cases. Next slide. The downside of this is that it is an injection and it's a frequent injection of 3 times per week for most patients. This is also very expensive and not covered by insurance and is typically between $100 to $200 per month in addition to whatever other treatment these men need. So this is a good option for certain patients, but is not always the best option, depending on the goals of the couple and the patient, and how willing a man is to come off testosterone if indeed he'd like to restore his fertility. Next slide.
All right. Thank you, Dr. Lundy, and thanks again to our panelists for this for these great presentations. And I would like to next figure out how to, we just stop sharing for a moment. Sure, I can see our questions. And then let me just share this one more time. Okay. So a couple questions here that I wanted to start with that some folks sent in earlier. The first question is, let's say maybe we have Dr. Lundy answer this one. Will testosterone replacement therapy help after prostate cancer radiation therapy?
I think testosterone therapy is a very reasonable treatment for men who have low levels of testosterone, even if they have prostate cancer that's been treated. But it is a discussion that needs to happen. As we know, prostate cancer does respond to testosterone, and in many cases, low testosterone is needed to prevent progression of prostate cancer at later stages. We do, however, know that men who've had their prostate cancer treated and are stable are perfectly safe candidates for testosterone therapy if they are monitored appropriately. And so I think for certain men who have symptoms that are related to low testosterone, who benefit from testosterone therapy and are willing to be monitored carefully by their physicians and urologists, this is an option. As Dr. Bayich hinted at earlier in our presentation, however, sometimes this is not the best treatment for erection problems only after prostate cancer treatment. And sometimes we focus our efforts on other treatments for erection problems if things like low libido or lower energy are not present as well.
Yeah, thank you, Scott. I completely agree with everything you said. The one other thing, I guess, that I just want to make a quick comment on is many men who have undergone prostate cancer radiation have also been treated with what's called ADT or androgen deprivation therapy, basically turning off the body's testosterone to make the prostate cancer more sensitive to the radiation during the radiation treatment and for a period of time afterwards. And depending on the type of cancer, the duration of hormone suppression therapy, could be a short-term or a longer-term treatment. What we don't know is how much effect that has on a man's eventual recovery of their testosterone. So some men, once that treatment is completed and it wears out of their system, their testosterone level will go back to, an appropriate range where it's not in a deficient range. But some men, they never really recover their production. So when we see men that have symptoms that could be associated with testosterone deficiency, who have a history of hormone suppression therapy during the time of their radiation, and as long as their prostate cancer is well controlled and treated, and the cancer team is satisfied with the PSA levels, in those patients, if their testosterone does not recover, we can oftentimes consider treating that testosterone deficiency to see if those symptoms improve. But we need to do so very cautiously. And in men who have metastatic prostate cancer that's spread outside of the prostate, typically we do not offer testosterone replacement for those men because that is a situation where it could put fuel on the fire. And one interesting, concept that's been gaining some traction in recent publications that have been coming out is having a testosterone level in the normal range may actually be protective against the more serious types of prostate cancer for men who don't already have it. So really our goal is not to put the testosterone level into some, range above what's considered appropriate or normal, but for men who have a deficiency, just to get them into that normal range, and not only would that be expected to help any symptoms associated with that, but there might be other benefits that definitely need more research for us to understand what those might be. So I'm going to move on to the second question that we got in email, and that was this could be one for Dr. Parekh. Are the oral testosterone agents FDA approved?
Yes. So the three options that we discussed today are all FDA approved. That's again goes back to the safety profile of the newer oral testosterone options, which allow them to obtain that FDA approval. And with that FDA approval also allows a few of those pills to be covered by insurance. There are both cash options and options to use your insurance to try to obtain these newer pills.
I have a question just for Dr. Parekh, because I know you have a lot of experience with these. So, if a patient, let's say, is on, injectable testosterone or whatever it is, because that's what their insurance is covering, and their insurance, they're not able to get oral testosterone covered through their insurance. Could you give some just rough idea of like what, at least currently, what out-of-pocket cost might be if for somebody that was just going to either pay cash or go outside of insurance?
Yeah, that's a great question, and a lot of patients like to know this. So we talked about the three. So for example, Kysotrex is $150 for a 1 month supply. Tolando is also $150 for a 1 month supply, and Jatenzo is $185 for a 1 month supply, and that's only if you're paying cash and not using your insurance.
Thank you, Dr. Parekh. And this may not always be the case, but I know that currently with these agents being new, for our patients who are interested in trying oral testosterone, we do have an opportunity for them to potentially even get the first month of the treatment for free. So for any folks out there who are interested in discussing this further and trying oral testosterone, certainly make an appointment with somebody from our team, and we're happy to discuss if it seems that might be a good fit for you. A couple more questions came through here. I'm going to direct this next one at Dr. Bole. So how quickly can you start seeing results from testosterone replacement therapy? And is there a certain type that shows quicker results?
Yeah, great question. So I think it depends on the symptom that we're looking to explore. So a lot of people can tell just a general change in their mood and quality of life, just feeling in maybe about 4 weeks or so, but you're going to take a little longer to see maximum benefits. So I would generally say try it out for 3 months, maybe even 6 months. By that point, you should be seeing some differences. So you might have noticed something early. It's going to take more than 4 weeks to notice a maximum benefit, but by about 3 to 6 months, you should know if you're feeling better or not, no matter what the reason was, whether it was sexual function, whether it was mood, whether it was energy, whether it was sex drive. And at 3 to 6 months, that's kind of when I would say, if you don't feel better, then we can revisit, whether it's something that is working for you as a therapy. Now, the one caveat to that is you always want to make sure that you're within the correct dosing range. And that gets to the second question that Dr. Veitch was kind of mentioning, which of these therapies is going to be faster to get you in the right dosing range. I would say injections are quite quick in being able to get you there, because they're going to go directly, into your circulation where you need to go. But that being said, each of these treatments, whether it's topical or oral or injectable, or the nasal will cause you to have a spike in your testosterone that day. And so I think the main issue to focus on is what's going to be the therapy that's most feasible for you, and what are you going to remember to do? What's going to be, do you have a phobia of needles, or are you okay with them? Do you have someone living in your house and you're worried about transferring a gel to them? Are you someone who's going to remember to take pills every day? I think those are probably the biggest issues that you're going to want to look at when you're trying to choose the right therapy for you.
Thank you, Dr. Boley. And I'm just going to give a couple comments to piggyback on that. But before I do so, I just want to invite anybody else who is here listening and watching this, who's interested in asking any questions. Please feel free to type them down in the chat. There's a button in the bottom corner of your screen. We've got a couple more minutes left. We'd love to answer any additional questions that you have. So yes, I agree with everything Dr. Boley just said. I do think for folks that might not be as familiar with testosterone replacement therapy, I want to emphasize that this is a hormone deficiency and that these treatments are not, unfortunately, able to kickstart or jumpstart your body's natural production. So these are expected to be lifelong therapies for men who are deficient in these hormones. So when we have you on this treatment, if after a period of time of being at appropriate levels based on following your blood work, if you are not feeling improvement in the symptoms that we were trying to address, that would be a reason to consider stopping the treatment after communicating with, the provider that prescribed it to you. Because as I mentioned at the beginning of the presentation, many of these symptoms are kind of vague and can be due to a lot of different things, maybe just aging by itself. So just because you're experiencing a symptom like fatigue and maybe you also have a deficient testosterone level, doesn't mean that fixing the testosterone level is going to make that symptom go away. Unfortunately, there's not really a way for us to know for 100%. And many times we just have to try the treatment and see how you respond to it, but giving it plenty of time to make sure that, we gave it the old college try, so to speak, and had you on it long enough, and also checking blood work to make sure that your levels were appropriate. So one other question came up here. So maybe this is a good one for Dr. Lundy. How do you monitor progress when a patient begins testosterone therapy? So maybe you could give some commentary on like some different types and how you would monitor progress in patients.
Yeah, I think it's a good question. I think progress can mean a lot of things. So first is symptomatic improvement. And I always ask at follow-up visits what type of symptom improvement patients are having or not, particularly with regards to things like sex drive, because sex drive is very likely to be related to testosterone levels, whereas low energy is a little bit more difficult to pin down only on testosterone. So we always ask about symptom improvement, and that's where a patient can provide really important information because I can't see how they feel. I can only ask. Progress could also mean level changes, though, and depending on the formulation of testosterone, we often check labs at different times. So for my practice, I have labs checked about a month after starting injection therapy. And I think it's important to check those labs at a consistent time, which for me is always before the next injection, so that we know when in the cycle of up and down those labs were drawn. And I like to see those labs about a month or 6 weeks after starting, and I like to see them in a regular range. We also check blood counts to make sure that that thickened blood we talked about doesn't happen, or if it does happen, we can recognize it and treat it to keep our patients safe. And we check that around the same time. And then because of sperm production concerns in some cases, if we're starting a medication like Clomid or anastrozole, we'll often wait a full 3 months to check sperm counts to make sure that they've been maintained, because believe it or not, it almost takes 2 to 3 months to make a sperm. And so we have to take a little bit more time in that regard to make sure that the counts are maintained. For other treatments, we vary those cycles a little bit. For example, for pellets, we check 2 weeks after the pellets to get our highest levels. And then I check about 3 months later to get the lowest level in the pellet kinetics, which are different than injections. So to answer the question, it really depends on the formulation, and we tailor that to the patient and to the formulation that we're using.
Thank you, Scott. And I thought of one other comment that I wanted to make before, and when you mentioned the thickening of the blood, it reminded me. So when we're thinking about other, factors that can contribute to these types of symptoms, and when we're thinking about monitoring the effects of testosterone replacement therapy, we're always looking very closely at those blood counts, particularly for the longer acting types of testosterone. But one of the things I think all of the docs here on this call do regularly is also screen men who are potentially going to undergo treatment for testosterone replacement therapy for sleep apnea. Sleep apnea, for those of you that don't know, is a condition that interferes with your ability to move air properly through your windpipe, and that flow of air is essentially blocked. That is a condition that can cause a lot of similar symptoms to the symptoms that can come from testosterone deficiency. And men who have sleep apnea are much more likely to have a deficient testosterone level, probably because that condition interferes with sleep quality. So you don't get as much deep, high quality sleep that we call REM sleep, which is when a lot of that testosterone production happens. So in those men, and we see these guys all the time, they come in with a deficient testosterone level, and if you ask them about their sleep, they report that they snore or they wake up feeling tired. And one of the problems with putting men who have untreated or undiagnosed sleep apnea on testosterone replacement therapy is that it can actually make the sleep apnea worse. So if you make the sleep apnea worse, instead of the symptoms getting better, they might actually get worse. So it's not uncommon for me to order sleep studies on men who have had these, and this is something you could ask your primary care doctor to order for you if you think you might have sleep apnea or if you snore. And we always try to sort that out first, because the last thing I want to do is make the symptoms worse or make their sleep apnea worse, which is associated with a host of other health problems. If you have a diagnosis of sleep apnea and you're under treatment for that, whether it's with a CPAP machine or some sort of mouthpiece, and it's adequately controlled, then that should protect you against having that problem, and typically would protect you also from your blood thickening, because blood thickens with untreated sleep apnea. So let me just kill this screen here so I can see if there are any other questions. I got one more here. So this is an individual who's in his 60s, had testicular cancer at age 29. Is testosterone replacement therapy possible for me? I had one testicle removed. Maybe Dr. Parekh, could you answer this one?
No problem. All right. So, as you pointed out, the majority of testosterone is produced from the testicle. And unfortunately, testicular cancer is a very common cancer we see in young men, which often requires removal of one of the testicles. Now, most often I counsel patients that you only need one testicle for sperm production and testosterone production, fortunately. But at 64, there could be a physiologic decline in testosterone. So really, before we answer that question, as Dr. Bayach pointed out, we'll need to get some more information. So that includes blood work, having 2 morning testosterone levels, ideally before 10 a.m., and also assessing, some of your symptoms. So I think an office visit with any one of us or someone specialized in treating this condition would be the best place to start, and we can go from there.
Yeah, thank you, Dr. Parekh. I agree. I will make one comment just about the different types of cancers. So there are certain situations with prostate cancer where we don't want to use testosterone, particularly if it's advanced prostate cancer. But with testicular cancer, it's not the same relationship with testosterone. So in general, men who have been treated for testicular cancer, particularly earlier on in life, who develop testosterone deficiency later in life, are certainly eligible for treatment. So that's definitely something I think that would be a good conversation to have with the urologists, as urologists are, have expertise not only in testosterone, but also in urologic cancers like testicular. So we're right on time here. We've gotten through all the questions. Certainly, if anybody who's watching this video later on has any additional questions or would like to have an evaluation or discuss testosterone replacement therapy or their erectile dysfunction or any other problem, please come and see us in our men's health and fertility team at Cleveland Clinic. And we're happy to discuss this stuff with you. And we do in-person visits, virtual visits. So this is something we love talking about and do every day. So I'd like to thank everybody for their attention. And thank you again to all of our presenters, and hope to see you all soon. Thank you very much.